Enrico.
Okay, last but not least, so we couldn't forget the airway scenario, and we have the privilege to have here one of the most important experts in airways diseases. So it's a pleasure for me to hand over the podium to Weder. Thank you.
Thank you very much, Enrico. I think we all love airways surgery, and it has a lot in common with hiking up a steep ridge. We do it rarely, it's fascinating, and the gap between falling down into a disaster or being on track is relatively narrow. However, in experienced hands, well equipped, with a clear plan, we can have easily good success. By having said this, airway disease, which end up in airway surgery, is relatively rare. It's often a challenge, both from the decision-making, from the perioperative management, and from the technical execution. But it can be done safely in experienced hands, and the three teams have prepared three very interesting cases. I think you will be fascinating, and please get started.
So we decided to divide the airway diseases into three subtopics. The first one is a tracheo-esophageal fistula, which will be presented by the European team. So I call the European trainee to the podium.
Thank you. So our case consists in a Caucasian 51-year-old woman with cardiovascular risk factors, and she was admitted in the emergency department from a type A aortic dissection, and immediate standing aorta replacement was done. The neurological recovery was poor, with cerebral ischemia, persistent motor disorders, and dysphagia. And the postoperative day 20 was needed to perform a percutaneous tracheostomy with bronchoscopy guide due to the prolonged intubation. Also, due to an infection in the sternal bone, a surgical revision was needed in the postoperative day 38. And in the context of sepsis, an aspiration pneumonia was obtained in the postoperative day 45. As you can see in these two beautiful pictures, we can see in the most highly pressured area a tracheo-esophageal fistula is nearly 1 centimeter below the vocal cords, and approximately is covering 2 tracheal rings. And also you can see in the endoscopy what is the balloon of the tube and the tracheo-esophageal fistula, which is also consistent with the inflammatory context, the ischemia, and the mostly pressure area due to the intubation. So the question for the Team Americas is, what is your initial approach? Step 1 for the treatment of tracheo-esophageal fistula. 1, surgical repair. 2, airway stenting. 3, esophageal stenting. 4, endoscopic closure of the fistula. 5, distal intubation and feeding tube placement. 6, no treatment, comfort measures.
Okay, now it's up to you. And so we have a wide range of alternatives, excluding lung transplant maybe, but we have all the options, from the more conservative to the more aggressive. So it's up to you, and it will up to you to support your right answer and to not support the other alternatives. Okay, almost done? Okay, good. Please.
So after our discussion, we decided that, can you put the options, please? Okay, thank you. The correct answer, in our opinion, is number 5, the distal intubation and feeding tube placement. We discussed that this is a very severe patient. He's still in the ICU with infection, and it should be better for her to recover first and then to think of a definitive treatment. Surgical repair, for sure, in the late time. Stenting, we don't think it's a good option for her in this moment. Another, do the endoscopic closure. And no treatment should not be considered. You should treat somehow. So the ideal treatment, in our opinion, is distal intubation and feeding tube placement. number 5.
Okay, excellent. So number 5 for you is the correct answer. So, go on.
So variable length cannula and a feeding jejunostomy was performed in order to slowly recover the patient from the sepsis and to try to isolate the tracheoesophageal fistula. Then with the idea to attempt the endoscopic suturing, Montgomery T tooth was inserted, and also you can see in these pictures how we perform with the Austichen Apollo system the suture of the endoscopic view of the fistula in the esophageal part. But unfortunately, as you can see in an endoscopy performed in the postoperative day 66, you can see that the tracheoesophageal fistula is still present. So the patient was evaluated for surgical repair, but the nutritional, neurological, and motor function was very poor and was sent to a rehabilitation program. And 11 months after the initial cardiac issue, she was referred to us for consultation after complete the rehabilitation program. So the question for the ASIA team is, when and how do you recommend surgery for tracheoesophageal fistulas repair? 1, timing is not important, depends on the surgeon. 2, prefer repair with muscle omentum interposition. 3, esophageal diversion with cervical esophagotomy and feeding gastrostomy without esophagectomy. 4, formal tracheal resection, direct suture of esophagus with interposition of muscle or omentum. 5, operate only when performance status is acceptable.
Okay. So again, time for the audience to vote. So these are scenarios that we all can see irrespective of the different continents. So there should not be any imbalance in the treatment options among the different continents. Hopefully. So 5 seconds left. Okay. Okay, good. So Team Asia.
Our answer is number 4, because after the patient is nutrition status has already improved, and the patient insisted to get the surgery, and for TOF, single stage repairment is possible if we can cut the fistula and make a tension-free closure of the tracheo and 2-layer closure of the esophagus. And after this, we should put a tissue to interposition between the 2 suture lines to prevent the recurrence of fistula. So our answer is 4.
Okay, so correct answer for the Asian team is number 4. Okay, so now it's time for scoring. Okay, so first of all, you have to score the presentation of the scenario from Team Europe. So we have 9, 9, 10, 9, 9, 10, 8, 8, 8, 8. So, very good score. Congratulations. So let's see what the score are for the answer from America. So, please vote. 9, 6, and 7. Arvin is 9, 10, 9, 10. 8, 6, 8, 9, and 10 from Steve. Okay. And finally, what do you think about the answer from Team Asia? According to the jury, 8, we got 7, 9, 7, 8, 8, 8, 9, 10, 9, and 10 from Steve. Good. Okay. So the second subtopic is the airway tumors. So we decided to assign this subtopic to America. So it's up to you.
Okay, thank you. Now the question about airway tumors. We have a 40-year-old lady was referred to our service with a recent complaint of cough and dyspnea on exertion. Physical examination was unremarkable, except for stridor and bronchial wheeze. And an X-ray was negative. This is a CT scan image, which was suggestive of a polypoid mass occupying 50% of the tracheolumen. You can see the image. So flex bronchoscopy revealed a polypoid lesion on the middle trachea, involving about 50% of the trachea. Biopsy of the lesion was suggestive of an adenoid cystic carcinoma. The question to Team Asia. Regarding its treatment, which of the following is the correct answer? Preoperative radiotherapy can be applied to reduce tumor length and improve negative surgical margins at operation. Tumor-bearing tracheal margins are unacceptable, and every surgical effort should be made in order to obtain a negative tracheal margin. Tumors invading the tracheal carina can be safely resected, since surgical morbidity and mortality does not differ from laryngotracheal or tracheal resections. Complete resection with negative airway margins results in higher survival than incomplete resection with positive margins, followed by adjuvant radiotherapy. And number 5, radiotherapy has a small role in the treatment of adenoid cystic carcinoma and should only be applied if in unresectable disease as palliative treatment.
Okay, so different options. Again, 5 different options, varying from surgery and multidisciplinary treatment and the problem of the resection margins and what to do with that. So different possibilities. Okay, are you ready? 3, 2, 1. Okay, supporting evidence for the correct answer from Asia.
Well, we have a very hot argument here. We cannot make a decision so far.
Somehow you have to decide.
We would like for number 4, complete resection should be achieved, but in this case it can be difficult. So we would go for the number 4 and followed by the adjuvant radiotherapy. And we have that opinion that cystic adenocarcinoma is sensitive to the radiotherapy, so we can in between number 1 and 4. So well, finally we make a decision for number 4.
Okay.
Sorry.
So in the end, you chose number 4.
4.
Okay, correct answer, number 4. Okay. Then?
Let's move on to the second question. Now the question to Team Europe. Surgical resection of the case was assembled in a tumor board. Please select the correct answer. Rigid bronchoscopy with core-out resection of the lesion, followed by radiotherapy, is less invasive and achieves long-term results that are comparable to surgical resection. Surgical resections should be defined intraoperatively. Airway tracheal margins are unacceptable, and every surgical effort must be made in order to obtain negative tracheal margin. Tracheal microscopic positive margins should be complemented with postoperative radiotherapy. Complete resection with negative airway margins does not result in higher survival than incomplete resection with positive margins, followed by adjuvant radiotherapy. Postoperative radiotherapy should always be performed in surgical cases, regardless of the AR status.
Okay, again, many options again. So we decided to choose also the airway tumors because even if they are rare, I think that they might be a challenge for any thoracic surgeon, and you should be prepared to treat them. So 10 seconds. Okay. 4, 3. Okay, Europe.
Okay, so we think that the correct answer is the answer number 3. Tracheal microscopic positive margin should be complemented with postoperative radiotherapy. Number 1 is refers to reed bronchoscopy, which will attend to a more palliative resection, but not radical resection like in surgery. And even if you complete this non-radical resection with radiotherapy, it's true that radiotherapy is less invasive, but our aim here is to obtain a free margin and to eliminate the malignancy from the airway. Number 2, we think it's not a correct option because we can sometimes we are not able to obtain air zero. So it depends on the situation and on the clinical case. Of course, the first aim is to obtain air zero, but sometimes we need to live with situation that we cannot obtain the air 1 because maybe the tumor is not completely in the endoluminal airway and has also extraluminal component, for example. The fourth option that speak that complete resection with negative airway margin does not result in higher survival is completely contrary with our option because we think that the survival is related with air zero resection. And the fifth option, postoperative radiotherapy should not be performed in all surgical cases, just in the case where, for example, as in the option 3, the microscopic margin is positive. So final option is 3.
Your final answer will be number 3. Okay. Great. So again, ready for the jury to score. First, we have to score the presentation, the quality, and how they presented. 9, 9, Julia 7, 9, Walter 10, 8, 8, 7, 8, 8, and 9. Okay? And next, the answer from Asia. 5 from Frank, 9, Juliet 7, Arvin 8, 8, 6 from Alessandro, 8, 9, 9, 7, Ricardo, and 7, Steve, okay? And finally, the answer from Europe, again, are you ready for scoring? Frank is 8, it's 9, 10, 8, 9, 10, 10, 9, 8, 9, and 9. Okay, thank you. So we are approaching to the last scenario. So we decided to address the issue of benign airway diseases, so which are not less important than the malignant. So please.
A 22-year-old man sustained right-sided chest trauma by a motor accident. On initial evaluation in the emergency department, he was noted to have a right pneumothorax with no evidence of rib fractures. He was managed with tube drainage, and his chest tube was removed on postoperative 10 days after complete lung expansion with no air leak. He subsequently presented after 3 months with left chest pain and shortness of breath. He underwent a chest X-ray. Here is the X-ray. Here is a question to Team Europe. What should be done next? 1. Repeat intercostal drain insertion. 2. Chest CT. 3. Fiber optic bronchoscopy. 4. Emergency thoracotomy.
Okay. 30 seconds. Again. Different options. So I hope you have clear in mind the chest X-ray, the difference in the transparency between the two hemithoraxes. So again, 10 seconds. 5. Okay. So we are looking for your answers.
So actually, our final answer is number 3, fiber optic bronchoscopy. The number one, repeat intercostal drain insertion, is true that in this case of complete pneumothorax, probably we can plan to do the intercostal drain insertion, but we have an antecedent, is that we do not have risk fractures and we have pneumothorax. So we cannot justify the pneumothorax due to lung effraction, and maybe the problem is in the airway. Second case, chest CT is good option for diagnosis, but the routinary and protocolized diagnosis of the airway, the tracheobronchial problems related to the trauma is fiber optic bronchoscopy, because we can know where exactly is the lesion and we can assess the diagnosis more precisely than with the chest CT. And emergency thoracotomy, I think, is not the case because the patient is stable, is in a stable situation, and we don't need to perform emergency thoracotomy, not for this case and not for an usual complete radiological pneumothorax. So final answer is number 3.
Okay, so let's see what our Asian friends did.
His fiber optic bronchoscopy showed a fibrotic stricture in the right main bronchus, 2 centimeters from the carina. Now here is a question to Team America. Which of the following consideration is true? 1. Owing to delayed presentation, his chances of lung salvage are worse than if he was diagnosed as initial evaluation. 2. He should be offered bronchial sleeve reconstruction, and his prognosis will be the same as those diagnosed immediately after trauma. 3. He should first undergo bronchoscopic therapies for both stricture dilation and stent if necessary to evaluate whether his lung is salvageable. 4. He should be offered a pneumonectomy since his lung is now likely to be diseased and atelectatic.
Okay, so ready? So now you have more elements to approach this patient and to offer a curative treatment. Okay, so it seems that you are all agree. Let's see if what is your correct answer. So 5, 4, 3, 2, 1. Okay.
So after our discussion here, we chose the number 3 option. He should go under bronchoscopic therapies first for bronchial dilation and with stenting, if necessary, to evaluate if the lung is salvageable. Going through the other options, maybe there is salvage for the lung. We're not sure if it's the same as in the initial evaluation, but we think he do. The sleeve reconstruction, it's maybe a later option, but we think he should go through bronchoscopic therapies first. And pneumonectomy, we don't think it's a better option for this case. First of all, he should go through other therapies first and leave pneumonectomy as the last treatment possible.
Okay, thank you. So let's see what the correct answers are. Oh, okay, then we have to score first. The presentation, the quality 779, 97, 8, 9, 9, 10, 8, and 9. This is the quality of the presentation. And how about the quality of the answer from the first answer from Europe? 9, 6, 8, 6, 8, Alessandro 9, 9, 8, 8, 9, and 7. And the answer from America, how did you convince it? 7, 9, 9, 7, 9, 8, 7, 8, 9, 7. We got 7. Okay. So I will invite Walter to provide us the correct answers. With your presentation, yes. You will have the The audience at the end?
Oh, okay, sorry.
Not the expert, not the audience.
Okay. So, what are the correct answers? So the first question is regarding the tracheo-esophageal fistula. And I think this was very nicely discussed by the colleague from the American team. He pointed out it is important, the timing. And this patient was already a very, very sick patient. So he denied to do upfront surgical repair, and he recommended endoscopic closure of the fistula, and he recommended the distal intubation and feeding tube placement in order to bring the patient through this acute phase. Anything else can be considered thereafter. And I think this was very nicely discussed by you. Okay, thank you very much. And then the second question, which came to team from Team Europe, was placing a tube, and how would you recommend surgery thereafter? And the correct answer is a formal tracheal resection, direct suture of the esophagus with an interposition of a muscle or the omentum. And also here, it's very nicely said. The timing is the procedure requires clean correction of the airway leak. And lastly, the airway tumors. The correct answer was that a complete resection with negative airway margins results in a higher survival than incomplete resection with positive tumor margins followed by adjuvant radiotherapy. And so finally, these are the references. And lastly, the trauma case, which is delayed. Sorry? Oh, okay, sure. And it is very well known that after in adenoid cystic carcinoma, that the margins can be positive and post-operative radiotherapy is indicated. And then finally, the trauma case. There was the case of a patient who had a pneumothorax in combination with trauma and came back 3 months thereafter. And here, I would say probably most people would do a repeat intercostal drain insertion, followed maybe by chest CT scan and their fiber optic bronchoscopy. But they expect that the correct answer is directly fiber optic bronchoscopy when you have a first recurrence of a pneumothorax, even after a trauma case. I think it's very difficult to consider the option that you have missed a tracheal disruption with this history. So I'm very surprised about the European colleagues who have identified the correct answer. Then regarding the treatment, I think it's also debatable. The correct answer here is bronchial sleeve resection upfront, and the prognosis will be good. I have no doubt about when this is done surgically correct. On the other hand, if surgical trauma is expected, it could be possible that at least in an institution where you have good interventional bronchoscopy, that you would select what the American colleagues have suggested, to do a bronchoscopic intervention and try to reopen the access to the distal airways to find out if the lungs were re-evaluation. So the correct answer, according to the team Asia, is the number 2, but I think it's debatable also for 3. Now,
see what the audience replied. Oh, this is the question 1. So the audience chose the right answer. Question 2. Again, there is very good concordance with the question 3. Very good. Question 4. Oh, excellent. Question 5. Yes, exactly as you explained. It's debatable. I think it's acceptable. And question 6. Very good. Okay. Good. So, your take-home message?
So, okay, coming to airway surgery. After a blunt chest trauma. This is extremely rare that you find out a delayed airway disruption. And there are, anyway, just a few cases described and observed. Overall, airway disruption is less than 0.5% of all chest trauma. It's mostly on the right side and in the main bronchus. Lobar bronchus disruption is less than 10%. The diagnosis is and can be a real challenge because it's often missed at the initial assessment, since patients have symptoms which are often associated with rib fractures or other injuries, because they have dyspnea, they have pneumothorax, they have subcutaneous emphysema, and often just other explanations are given for these cases. The delayed diagnosis of an airway disruption is often after weeks, months, or even years, and it is dyspnea, pulmonary infections, wheezing. CT images initially often miss a disruption when there is a gap, not a gap seen between the bronchial walls, because it can be in this envelope, bronchial envelope. It can be covered and just a little air leak which heals thereafter. Bronchoscopy at the end then finds fibrous tissue obstruction, which obstructs the lumen. And surgical repair whenever possible. It's usually also feasible, and it's often not much more complicated than upfront reconstruction. Laser ablation has only a temporary effect, and stent as a long-term treatment is also not a good option, since you have granulation tissue as a problem. We are probably most familiar with dealing with adenocystic carcinoma of the airways. About half of the malignant tracheal tumors are associated with adenocystic carcinoma. The diagnosis is often delayed because it's mislabeled as asthmatic complications with stridor, dyspnea, cough, and dyspnea activity. The mean age is around 50 years. CT images are essential, as shown here. It usually shows the tumor location, the size of the tumor, the length, the mural depth, and you can also evaluate the extrinsic component and the mural growth. There's no TNM system existing, and metastases are usually rare, especially in the early detection. Bronchoscopy is key for biopsy, for the location and the length of the disease. And in general, an AOS is done, an ultrasound of the esophagus, to find the involvement of the esophagus or exclude. However, even in close contact and extramural growth, it is not so frequent that the esophagus is also involved. And first treatment of choice, as shown here, is surgery, segmental tracheal, tracheobronchial resection and reconstruction, carinal reconstruction, and most often in combination with radiation therapy, because R1 resection is very, very frequent. Endoscopic resection is only done for deobstruction temporarily, and unresectability can be seen mostly due to the length of the disease and rarely because of metastasis. We all know we can resect up to 4, sometimes up to 6 centimeters. It depends from the constitution of the patients. Avoid neoadjuvant radiation. Use it palliatively in unresectable cases, but it is used, as said before, as an adjuvant treatment, usually 6 weeks after resection. The surgical mortality is very low in experienced centers, and the 5-year survival is approximately half of the patients. Now, finally, the problem of acquired tracheoesophageal fistula. I think all centers have experience with these problems, despite it is rare, usually a result of a penetrating trauma, mostly iatrogenic, either due to false intubation or traumatic intubation or tube pressure, and mostly located in the upper third of the trachea. Since most of these patients are intubated, the diagnosis is often delayed. It's aspiration of bilious secretion, aspiration pneumonia leads to esophagoscopy and making the diagnosis. The management, as shown in this case, requires usually a surgical intervention, but the timing is important. As shown in this case, you can delay and stabilize the patient by the tube placement distal to the fistula. You elevate the head preferentially to avoid further aspiration, and put in a feeding jejunostomy tube. Surgery has all kinds of variations. In general, a tracheal resection is straightforward. Very small holes can be directly sutured, and the esophageal lesion can be sutured, but we always require an interposition of a muscle flap or an omentum. The outcome, the surgical mortality, is usually higher, not because of surgery itself, it's because these patients are often very sick due to the septic state of the esophageal tracheal fistula. And they have prolonged pulmonary infection because you do surgery normally into a pulmonary infection. Thank you very much for your attention.